Welcome to another show of Healthcare Business Growth Conversations. Today, I'm joined by Dr. John Ferguson. He's a surgeon with over 25 years of independent practice, the president-elect of the American Board of Facial Cosmetic Surgery, and a global fellow working on algorithmic integrity and accountability in medicine. I want to level set for everyone listening. This conversation is not about new tools or trends. It's about how medical standards are defined, enforced, and protected at a time when technology is beginning to challenge the systems behind them. Most conversations around AI in healthcare focus on efficiency, productivity, or automation. This is not what this about. What we are really talking about today is medical truth. Who decides what competence actually means, how that decision is validated, and what happens when technology starts to pressure the institutions that have historically held that authority. Dr. Ferguson, thank you for being here.
Hey, it's a pleasure. Very nice to be here.
I know it's 3 a.m. for you in Hawaii. I appreciate your being
It
here.
is. Yeah, it's one of those sacrifices for living in the middle of the Pacific. It's worth it.
But very few physicians ever get to see how these systems are designed from the inside. You have spent years operating both as a practicing surgeon and someone responsible for maintaining standards. That perspective is where I want to begin with.
Sure.
So let's look at the broken engine. You have seen boards.
Oh, you got. Yeah, that's kind of what started everything. Yeah.
So you have seen the boards invest significant capital into manual exam certification.
Yeah.
Like,
it's
you're talking about volunteer burnouts and all.
Yeah. Well, see, I'm a professional test taker. That's most doctors are. You got SATs, MCATs, we got all exam. I mean, that's it. I mean, professional test taker. And that just kind of turned into a professional test maker for the board exams. And, I started making it. I started with making questions, helping out the boards. And it's tough. I mean, it really is. It's not like, I guess it is kind of easy. You take something, boom, okay, I'm going to make a question out of that sentence. That's not right. That's just not how you test somebody. So you got to put a lot of thought into it, especially when you're testing competency. It doesn't matter if their blood sugar is 283. That's the cutoff point. No, you got to understand what the ramifications are. You got to, it's just not pick the factoid. It has to be applicable. And you have a finite time frame and a number of questions you can test people. So it takes a lot of effort to make a valid question. Anywhere from, I've spent days just on one. Now, multiply that by 300 or 400 that you have to have every year for an exam. And then try to corral a couple of surgeons, maybe 2 or 3, to help you write the questions in time for the exam. And you know what? They all have better things to do. And as soon as I was kind of responsible for putting the exams together, I found out how hard it is to corral a bunch of surgeons to do anything other than operate. They don't want to do anything else. So I found myself doing all of these exams or all of these questions. But it was, you get burnt out. You put all this time and effort, you're doing all of this work, and you just get burnt out. So one day I started playing with AI and just said, okay, let's put it in there. Make me a question. Beautiful question. Beautiful. I just typed in, we've got a patient that's coming in with a hematoma after a facelift. Boom. What do you see? And it get this beautiful question. And it was completely wrong. I don't know where that AI got its data from, but it was like nothing that we would do. So that's when I started applying, really focusing on the content, not so much the question first, but the content. We'll get into this later, but to me, that's the basis of AI. AI is great at what it does as long as it has the right content, the right data. You can have a Lamborghini, but if you don't fill the gas tank with good gas, it ain't going very far. So, I started focusing on content, and that really was the key to making really good, validated questions. And it really helped make a difference in time. I mean, with my software, okay, this is going to be a little, I had a contest one, or somebody just kind of bet me how I could make questions. I did in one football game. It was Dallas versus Philadelphia last year. We got our butt kicked. I'm from Dallas, and during that game, I made 1,052 questions.
Wow.
That year, 100 of those were actually about 100 of those were on the exam. So, it makes a big difference. And those are all validated questions. I mean, we go over them in committee and make sure, because there should always be, I hate saying human in the loop, and we'll get to that later, but should be AI in the loop. But we're testing competency, and AI doesn't operate. So as humans and doctors, we go over every question, but 94% of the questions never need any editing. That was kind of the key moment that brought everything together as far as the validity of the process and the questions.
Well, let me pause you there for a second.
Sure.
So, like what you're describing sounds less like a cost problem, more like a design problem.
Well, yeah. I mean, that's the problem. I mean, that's the whole thing. The system is screwed up. And it's screwed up in multiple ways. There's a whole industry on questions, just questions, and that's it. There are people that have PhDs in writing questions or validating questions, and they charge a lot of money. I've been treasurer for a couple of boards, and I sign the checks for $50,000, $60,000, $100,000 a year for these experts to validate our exams. We're still writing it. We're still doing all the work. And they're just validating whether the question is strategically or tactically, whatever, correct or valid based upon statistics. This gets into the healthcare medicine thing, but I don't treat statistics. I treat patients. The person on my table is not a statistic. That's a patient. So matter what on a question, what the doctor next to me answered on that question, it doesn't matter. And that's how they were validating questions. Placement by ranking. I have sat in so many rooms, and you have this expert, the psychometric expert comes in and say, okay, in order for your test to be valid, for these questions to be valid, a certain number of people need to fail. What? And so you have to pick an arbitrary point. I'm not, you have to put, and that point right there determines whether this person operates and this person doesn't. An arbitrary number. And God forbid you have that so many, if it's too many people passing the test, then your test is too easy. If you don't have enough people passing your test, then, it's not the test, your education, your training sucks. So it was an unfair system. I got caught up in it once where it affected me. And so that's when I decided to really start focusing on not just medicine, but and board certification, but the whole process of competency assessment. Right now, assessment, examination, it's all question centric. It's been that way for eons. Well, not eons, because Socrates had a completely different idea that we'll get into in a little bit, but it's like a diamond. They treat it like the whole diamond industry. You have somebody that goes and they mine that diamond. It's very labor intensive. They carry it across the border, whatever Leonardo DiCaprio did in that movie. And then you spend hours and days and months and weeks just trying to refine it and make it beautiful. And, and then you put it in a vault and hoard it so that the price stays, so it stays valid. It stays artificially inflated in value. It's safe, because if it gets out into the world, it loses its value. What's the difference between a diamond that's you get out of the ground, you polish it, you do all that kind of shape, and you shape it, and when you manufacture? What's the difference besides De Beers? There is no difference. And in fact, for manufacturing purposes, manufactured diamonds are better because they're flawless. They can be used in very exact manufacturing processes that need diamonds, because there is no room for error in some of those processes like you would get with a diamond that it goes through so many iterations to be able to say, oh yeah, I'm ready for an engagement. So that's kind of the approach that I took. AI made it possible. Once you kind of grasp how the questions are manufactured, or how the psychometric specialists, they have a formula. That's how they do. They come in, they have no idea about rhinoplasties, about, a radix graft and how it goes up periostal. They have no idea. How can they read these questions? Well, they have a formula that they go by. Okay. Stick that formula into AI, put your content in, and there you go. And that's what I did. I manufactured those questions. The key, though, was really being able to get the AI to focus on the content. And so instead of question-centric examination assessment, it's more content-driven. The value is not in the question. The value is in the content. And that's what it should be. A teacher shouldn't be punished for being a good teacher. They shouldn't. A good surgeon or a doctor or clinician shouldn't be punished because they're not a good test taker. They should be rewarded for their knowledge. And Microsoft proved that the current assessment, most tests nowadays, it's not knowledge, it's test taking skills. And I know that because I know I got test taking skills. I can go in and not study for a test. I didn't study for the SATs, and I was a national merit finalist, because there are ways of getting around that with not having the knowledge but taking the test. And Microsoft proved that AI can do the same thing. And so you really need to, making that question is very important. If you know how to do it, you can cheat the system. So really, it needs to go back on the content. That's what we did here, is something called content-driven intelligence. Making the questions was really easy. It was figuring out a way to isolate content so that it stays there. The AI doesn't go drifting out and pull something in. And that's actually the patent that I got 13 months ago or whatever, was basically that process. Not so much making the questions, but being able to process the content in a way that it can be used by the AI, and without worrying about hallucination or drift or anything.
Yeah, definitely. We'll get into the hallucination part later. I just
Yeah.
want to take a step back and then say, now you are spot on whenever you said, now, whenever you took the example of the gold being mined versus gold being manufactured in the lab.
Yeah.
So there is no error whenever you manufacture it in the lab.
Exactly.
So,
Exactly.
yeah, like on the same note, if a system assumes failure is necessary to prove legitimacy, then excellence actually becomes a threat to the system, right?
Exactly. That is spot on. And that's where the paradox arises in education. It's become such a competition, and God knows I fell into that. I mean, if I wasn't the first one done with the test and didn't get the highest score, I I felt like I failed. That's not important. Um, you know, I that's superfluous to what you're trying to achieve. But that's what was rewarded. And it wasn't so much, the knowledge, it was just being able to take a test. I mean, and some people can't take tests. Some people aren't good at it. Some people need to think and, they know that they have it up there, but bringing it out takes them a little bit longer. And, you have to have a time limit just for logistics purposes, but some people need a little bit more time. Some people don't. Some people don't process the same way as they read. Some people don't do well in a big room full of other people. Some do. I mean, there's a lot of variables, and anything other than being really good at taking a test, you were penalized. That's not fair. Not fair at all.
Staying on that point,
Yeah.
okay, then I just want to go a little bit deeper into it.
Sure.
Which is the mastery paradox, I would say. Uh, when candidates perform too well, psychometrics often conclude that the test was too easy, as you said. So why is this logical fundamentally backwards in a profession where mastery, not a bell curve, should be the goal?
Well, that's when how you assess is the focus and not what you're assessing. That's the problem. All right. And that's what has happened is it's the process that's what people concentrate on. And it's a big, huge industry of making sure that your test is validated. And it's insane. I mean, we pay consultants on boards hundreds of thousands of dollars to validate our tests. And it's not because our tests are bad, it's because it's expected. This board does it that way, so we got to do it this way. Their test, it goes every 2 years. They sit down and they do the psychometric reevaluation every 2 years. So they must be great because they're going over their question bank constantly. Dude, why don't you just write questions? Just do new questions. The questions, that whole process should not be the focus. All right. It's the content that should be the focus. And it's not, because it's the whole manufacturing of the assessment material is so onerous and time consuming and resource consuming that a whole community of businesses developed around it just to support that. And they have a stake in the game now, and they'll help perpetuate that also. And you can't blame them. I mean, imagine if you went to school, a PhD. I mean, Jesus, that's years and years and years. And that's when and there's that fear that AI is going to take your job. Well, you know what? That's in a way, that's kind of it, if that's what your job was. But now it's time to pivot and support AI is doing. Make better algorithms for the AI to make questions. Don't try to perpetuate a system that is no longer necessary and is detrimental.
Yeah. So I just want to go a little bit out of the scope and then ask you one question regarding this.
Okay.
Uh, because the depth was good, so I couldn't control myself. Uh, like whenever everyone starts depending on the AI for the, for the pattern recognitions or for the for like for example to be in a layman terms to do the basic research work. So are we training the next generation uh, into algorithmic thinking? Meaning, can we notice everyone's cognitive ability is as good as these AI algorithms?
Absolutely. It's better. AI frees you up. You know what? Do you want me? I have a certain skill set that I have developed over time. But no, is my time better spent in the OR or making a question? I can do both. AI can't go in there and operate. It can make my question. Where is me as a resource? Where am I better utilized? Yeah, I can do it. I can make a question. It's going to take me 4 or 5 hours, 40 hours, whatever, but I'm going to make as good a question as the AI. But that's time that I could be learning something else, helping somebody else, operating, surfing, petting my dog, whatever. Uh, it's not, it's freeing. It lets me do more. I can concentrate more. I can take that time that I'm not writing a question and creating new content. You know, that's what it should be. It should be focused on what you're testing, not how you're testing it. We know how to test. We know how to do that. We got it. It's time consuming, you know. I I mean, a washing machine. Have you ever washed your clothes by hand? It sucks. It's time consuming. It's awful. And you know what? A washing machine does it a whole lot better. Did we give up any cognitive or physical abilities by letting the washing machine wash our clothes? We still got to put stuff in there and decide what's in there. And if you screw up, everything comes out pink. We still got to put the laundry detergent in there. We got to decide, oh, God forbid you put the bleach in there. Who's going to take it out? Who's drying it? Who's folding it? Who buys the clothes in the first place? All right. It's not the washing machine's fault. Washing machine didn't make us lazy. It's just doing something that we can do quicker, and it frees us up to do whatever. Take the dog for a walk, read a book. And that's kind of it is. It's a tool.
Yeah, totally understood. So let's sit with that for a moment.
Okay.
So once you recognize that inversion, you can't unsee it, right? So at that point, the issue stops being theoretical and becomes a leadership problem.
We're seeing that. I'll get into, I just got to throw this out there because this came up, in the last, day or two, especially in Psychology Today, they came out and we're reaching this plateau of everybody starting to listen to the AI engineers now, the leaders, the C-suite people who just see the money and they want to have a one-size-fits-all everything. That leadership is coming to terms. reality is sitting in, and the people on the ones that doing all the work are bringing reality back in, and that's kind of what it takes. What I'm kind of facing with the boards. I mean, this is, first, it is a money making thing. There is money to be made in some of the larger boards. So there's that inherent interest, but there's inertia. We've done it this way for 150 years. We can't stop. We can't do it. And you mentioned before that there's this stigma or of using AI, that it's making you lazy, but it's doing the thinking. You know what? You got your phone. You know what? I don't know any phone numbers anymore. Does that make me dumber? No. That I got a lot stuck up in here, and that's valuable real estate. I don't want to burden it with a number. I want to do something else with that idea, that this is going to change something, that it's going to make you lazy, and we've doing it this way for so long because it works. I all know it doesn't work. We use incandescent light bulbs for years, and it's all we had. People don't want, we've had LEDs forever, but they weren't as bright. They weren't as warm. They couldn't work as much. Well, no, because they're not wasting so much energy making heat, but people want to stick with those because tradition, I don't know. And before that, they were afraid of electricity. Let's light everything up with fire. That's safe. But no, this electricity is going to kill elephants. But so, that's kind of what we're facing in boards. I'm at that middle stage. Well, I like to think I'm in that middle stage of my career when I'm not the old, professor, this is how it is, and not the young, I'm in that where I have enough knowledge, new knowledge, but still am ready to learn. I hopefully aged isn't a reflection of that, but as those my colleagues that are in this same field and embrace technology, it's slowly changing. When I was a resident, laparoscopic surgery, there was only one attending that taught laparoscopic surgery. All right. Now there's cries out in surgical residencies because they don't know how to do surgery without a laparoscope. It's there's inertia, and it wasn't because the scope was a bad thing. Obviously it wasn't. It's because it's something different. It's something new. And, you kind of get scared of something new. People are changing. And those of us that, God, I feel old when I say this, but those who are moving into those, those positions of respect and all that, we're able to break some of those ideas with us. And, I have to admit there's a couple people that are much more experienced, smarter, older than me, that know this a whole lot better. And it's always kind of cool who gets it and who doesn't. But it's a race. It's not even a race. It's a marathon. But it's getting there. People are coming around and realizing that it's not the boogeyman. It's just not. It's just don't make you better.
On the lines of those responsibilities, as you step into the president-elect role for the ABFCS, how do you balance the mandate to modernize certification with the need to protect institutional legacy and patient safety?
First and foremost, anything that we do up here, patient safety, everything else is way down here. That's the whole idea behind this, is patient safety. Do you want somebody operating on your grandma that can take a test, or do you want somebody that knows the material? That's patient safety. Do you want somebody that can memorize all of these equations and all that, or somebody that understands those equations. That's what we're doing. Explore it. We're able to tap in those boundaries of knowledge in a more fair, equitable, thorough, I mean, just better way. It's, you know, being this is allowing us to better to assess physicians better, assess their knowledge, but in a way that isn't so resource dependent. We can't do an oral exam on every single question and tap some individual's knowledge. We can't do the Socratic method on every single patient or every single person taking a test, every single doctor for every single question. We can't do that. We have to, it's just too resource dependent. But if you can create an assessment item and a question that really stretches every aspect of your knowledge, being able to recall a little information, recognize what's going on, and analyze the situation, process it, and then synthesize something out of that. That's the process that we go through every single day, every single moment when we're seeing a patient. The patient doesn't walk in and say, I've got this black spot here that's irregular. It's been there for 6 years. It's changed dramatically over the last 6 months and it's bleeding. They don't walk in like that. They don't walk in and say, with a diagnosis, oh yeah, melanoma, gotcha. No, you got to explore. You got to do all these things. And to make a question like that is very, very, very labor intensive. It's resource intensive. It's doable, just like you can make a really, really pretty diamond out of this rock that you get out of the ground, or you can just get a machine to make it for you. It's the same. It serves the same purpose. Doesn't matter how you get it, just it does that. And that's I guess that's that's what makes this kind of not it's not revolutionary. It's just freeing us up. And isn't that what moving forward, modernizing every generation, it's not that it gets easier. Well, yeah, it is kind of easier. You're making it easier so that you can spend time on the next iteration, something that expands upon that. You're not wasting your time pushing the plow across the field. Oh God, let's put a mule in front of that. Okay, that frees us up. We can make more. Oh, let's get a tractor. Okay, that really frees us up so that we can build a city, and somebody can be a blacksmith, and somebody can be a trader, and somebody can learn to sing and entertain those people. It's everything is it's not to take away from society, it's to make it better. And I know this is going a little bit more deep than just making a question for an exams, but it shouldn't be scary. Its goal is to make us better. Give us something that we know how to do. AI doesn't know how to do anything that we don't know how to do. It just does it a lot quicker. I can deal it. I can dig a well. I don't want to dig a well. Just get some machine to do it. I mean, it's that easy. Shouldn't be scary.
Yes. Uh, that's deep. So I want to reset the frame slightly here. So
Sorry,
yeah,
I
yeah,
too much.
just to go deep. So
Now it's 4 o'clock in the morning.
Well, it's a good time to go deeper, focused on
Okay.
the topic. So, as I said, I want to reset the frame slightly here. So
Sure.
we have talked about what's broken structurally. Now the question becomes what assessment should actually means if outcomes are the goal. Right. Starting from first principles, if the traditional exams measure recall rather than competence, what should assessment actually be measuring if the ultimate goal is improved patient outcomes?
Well, now you want to go into the whole Bloom's taxonomy, and actually, there's somebody who has the anti-Bloom trademarked anti-Bloom thing. Well, I mean, there's the philosophies and the whole, the whole specialization of learning. I mean, that's I grew up with teachers. I mean that this is what that whole process of learning stuff and what you're testing. I mean that's first year teaching school, uh, and those of us that didn't go teaching, it's really it's almost like a black box. But once you're in there, I mean, it all kind of makes sense. It's just as formulated and regimented as of playing a game or writing code. I mean, it's there. And I'm lucky because both my parents were teachers. And I grew up grading papers of all things, and writing tests, helping my parents write the test. Now they were college professors, so it wasn't as much as it is K through 12, but there are it's not recall doesn't really mean a thing. It's moving beyond that. There's gathering information. There is analyzing information. It's again synthesizing information, and really for medicine, it's gathering, processing, and synthesizing, doing something about it. And in medical school, they teach us, first of all, how to talk. Medical school is 50% language school. There's a reason. There's no reason for us to talk that way, except it makes us sound smart and we can communicate with other. So, medical school is learning a new language. The other part of medical school is gathering information. All right, data collection, and that goes into that is a testable skill. All right, it's a teachable and testable skill. Beyond recall, there is gathering. You got to know what to gather. You got to be able to elicit that. That's one aspect of testing. Another one is being able to recognize the significance of what you gathered. That's testable. That's part of medical school. You got to be able to process all of that different data. That's a testable skill. You've got to put that into a cohesive idea, like a diagnosis, which is a testable skill. And then you got to figure out what the hell to do about it. You got to synthesize something. Those are all testable skills. And that's just Bloom's analysis that any first semester teaching student learns. But they're all testable, and they are all quantifiable, and they are pretty formulaic also. We in medical school, we're taught differential diagnosis. You got to come up with a differential diagnosis. You're creating a different, before you do anything, do that differential diagnosis. You know what that is? That's turning medicine into a multiple choice test. All right. That's what you're doing. You are creating a multiple choice test out of that case. You got your differential diagnosis. Then you got to pick which one it is. That's what we're doing. We are taught a diagnosis. Making a diagnosis is making a multiple choice test. I mean, that's what it is. So, yeah, it's easily teachable and it's easily testable. But that, to be able to write an assessment that touches upon all of those kind of gets, once you, I mean, you can imagine how hard it is to make a question that STEM that encompasses all of that. And within 4 choices, it has to go, you have to go through so many thought processes from here's the data or here's this. The funnest things, what I do with the exams, with the questions that in my program is case studies. We give you a case and then had 2 questions on it. And then it throws something at you. And then you have to respond to that, or it asks you to gather data. And if you didn't gather the data, you can't move on to question 3 and 4. I don't write those questions. I wrote the formula. AI does that. I just tell them I just give them a paper, write case studies, protocols on that, make it 4, 6 questions, put the confounder here, and it fills all that in. Because it's just all formula. But each aspect of learning and assessment learning it's objective. It's not subjective. I mean, it's purely formulaic at all. I mean, it's just an algorithm. You have to change the variables here and there, but it's just an algorithm.
Then that reframes the entire purpose of testing, right?
Yes, I mean, it really does. It's not the test anymore. All right, you don't have to focus on the test. Teachers shouldn't be having to write these big old tests. I mean, it's not necessary. They should be working on the content. They should be focusing on that. Spend that time that you're writing a test or making a test teaching or making new content. I mean, and that's what progress is. That's what being modern, that's what progression is. They can find, having a problem, fixing it, and you don't have to deal with that anymore. And you can move on to something more important, like teaching, instead of writing a damn question or a test. Spend your time teaching. We just wrote a grant proposal for K through 12. And using the content-driven intelligence to free up elementary school teachers, high school teachers, to free them up from having to spend so much time writing questions and more time teaching. It goes. Don't worry about assessing somebody. Worry about preparing. And that's what it should be.
Okay. So if recall isn't the objective, ranking physicians against each other starts to feel the wrong problem. So staying with that shift, you have moved from question-centric testing to content-driven intelligence. Why is anchoring assessment in validated medical content more defensible than ranking physicians against one another?
I'm a perfect example. I got into medical school with a 2.8 GPA. All right. I shouldn't have. Yeah. But I missed one question on the MCAT. I could take a test. Okay. I made up for it in medical school. I did pretty well in medical school. In fact, I stayed tied for first in my class until I matched. And then I didn't really care because after that, it didn't really matter. But it mattered because it was measurable object. It's very easy to measure rank. It's very easy. So I did an ENT residency. Notoriously difficult residency. There are like 3 or 4 residencies that they actually do early matches for because half the people don't match and they need time to figure something out. One of those is ENT. One of the persons that was also first in my class, because there was a few of them, she didn't even match an ENT, and that's what she wanted. So, that is a that helps those program directors and residency coordinators. That's a badge for them. We get all those those that are first in their class. Hey, I was first at Harvard. Hell, Harvard, what the hell? I got just as good of an education, but we rank these things. I mean, it's assigning. It's a competition. It's not assigning a person's unique value. It's not about them. It's about them compared to others. I mean, it's a bell curve. Why? In the OR, somebody that's just on that side of the bell curve, you don't want a bell curve. You want a binary. Can they do it? Can they not? All right. There shouldn't be any of that. I don't know. I mean, we live in a competitive society and it's a subjective measure. And I, for one, am extremely guilty of being a very competitive person. And it's taken a lot. I pretty much reached my goals, and what did I wanted to do. And now it's easy for me to say competition isn't important, but looking back, it really isn't. It's what you know as an individual. Be judging competency against somebody else. We should be judging competency on error rate. That should be important. Now we get into, okay, do they have 1 error per 100 or 1 error? But it's, unfortunately, we live in a competitive society. It's ingrained genetically. It's the most competitive winner gets to procreate. It's been like that for billions of years. So it's going to be hard to get out. But when you're talking about the difference of somebody standing over your grandmother with a knife, it should be a binary, not somebody, do you know this or do you not know this? Not, can you take a test? Yeah, that gets a little deep. I know. I get like that. On you close. This is I'm passionate about this. I mean, it's yeah. I mean, I'm so passionate. I'm willing to give up a career as a surgeon to pursue this, because it's important. I've seen so many in medical school, so many people that would be such incredible doctors, incredible, but they can't take a test to save their life. And I would have any one of them be my doctor, but they couldn't take a test, and so they didn't survive.
No, the implication of that is bigger than it sounds. So,
I live it every day.
So, everything you described works only if truth is stable and controlled. In medicine, even a small hallucination isn't a feature, it's a catastrophe.
You can't. That's where, I see where you're going with the content control. You got to control the content. You can put some gas in that Lamborghini, but if you sprinkle a little bit of sugar in there, it's not going to work. Gas is great, but if you have a little bit of something a little spoiled in there, and it's the same. I mean, that's everybody's. That's the thing with AI right now. Everybody's worried about drift and hallucination, and they're working on, increasing the ability to predict wrongness. What the hell? I mean, that's crazy. Reducing error rates so that it's 0.001. They're neglecting the primary cause of it in the first place, which is easy enough to treat. Don't put in bad data to begin with. Control the content. It's a little, it can be a little bit more resource intensive, but and it's fine. You can have a little bit of hallucination if you're having AI write poetry or copyright for, I don't know, some journal. But there's no room for a little bit of error when I keep on going this. Uh, there's a whole long story behind the grainy thing, but anyway, you know, if your error rate is 1/10% in the OR, that's one out of a couple thousand grannies that die. That's not allowable. So the goal isn't to reduce error. The goal is to not introduce it in the first place. And so you control the content. And I can tell you that was the hardest thing. It's being able to focus the question on the actual what you're offering it to use. But still have a little bit of flexibility to make every question different, every scenario different. And it's not just, okay, make this 25-year-old patient and this 60-year-old. I mean, everything needs to change. And so you got to have that flexibility in the actual creation, but the overall insight or pearl or goal that you're trying to assess has to be 100%, because it's got to be 100% right when you're in the OR. I mean, that's just the way it is. And so you don't introduce content. It's kind of like Plato's cave, I mean, those people staring at the shadows on the cave wall, were they any, whatever they described, it's right. In their mind, it's completely right. And, there's no hallucination. There's no drift. There's no guessing, because they don't know anything else. All right. I got into a big, long philosophical discussion yesterday with somebody. Well, our algorithms are, when we process, it's processed by 3 different algorithms, and then they come together and fight about it, but whoever wins. Well, that's the whole goal, is they're guessing. So, if they team up, they'll, what? Just don't give them anything to guess about. All right. Take that away. I mean, sure, it's inference. That's how we work. We work in inference. But you know what? We're not guessing. You can't guess something that was never there in the first place. So you just control the content.
Well, this is interesting. Okay, like now I want to go deeper into this. Like maybe more step deeper. So staying with that risk, whatever the risk that you said, I want to talk about reducing the gap, the hallucination gap. I know it is not perfect, but at least let's talk about reducing that gap.
It can. You can reduce it to 0.
Well, so for
everybody rolls their eyes. Okay. You're only as good as the data. So if I put in data that's not true, then I guess, is that a hallucination? I don't know. You got to put some guardrails on there. And I know I'm not going to convince you, but I just keep on going back to Plato's cave.
Yeah. So on the same line, right? Like what design principles actually reduce hallucination? Maybe now, to put it in your terms, make it 0 in high stake environments, as opposed to just hiding it.
Mm-hmm. Yeah. So that's what we'll get into that a little bit later when we talk about healthcare and medicine. But everything that I think about when I do healthcare and medicine stemmed from this, from making these questions. It was so important that when I'm making a question, that it doesn't have anything, it can't hallucinate, it can't make anything up. The one of the golden rules of making a question is everything about that has to be in that content. You can't go anywhere. You can't get any it. Everything has to be right there. Uh, and if it's not right there, then it's not a valid question on that material. It's got to be all encompassing. So, how do you get that to do that without just, you know, picking a fact and saying there it is? Well, you take that contact and you chunk it. That's what it was. That's where I came up with it is, before I even knew what chunking was, I would break it up into different, pull out the ideas that they were trying to, the goals of the article, the objectives, the learning objectives. You pull those out, and then you have those as keys, and then you do you chunk them physically, like what's around them. 500 words before, 500 words are characters afterwards. Where is it visually on it? Is it in a table? Is it in a traditional area that's the results? If you're talking like a method, a journal article on an experiment, you do that. How is it? This is kind of crazy, but is it bulleted? Is it italicized? Chunk it like that. When I break it, when I get an article, I broke it into so many different ways of looking at it, so that there's enough that it can create something without going somewhere else, but not making it word for word out of the article. And the really key, I think, that I don't know what, I just lucked into it, was don't layer it. Don't have multiple layers. When I would chunk it by number of characters back and forth, that's one index. If it's by position in the paper, that's another index. And then, where it is visually or how it is, that's another index. Those act independently. They don't cross talk at all. And then there's a layer right above it. That's the layer that makes the question. There's nothing in between. There's no real room. And that just came out, Google research this week. The more layers of agents you have, once you get past 2 or 3, you're done. Hallucination, error, it outweighs any validity whatsoever. That's kind of how I did it. And there was twofold. One was making sure that wouldn't introduce any error. And second, it was really so that I wouldn't run into copyright issues, because you can't copyright an idea. So, I mean, it kind of all worked from there. And it's going to be a story that lives in my family forever, because last year at Thanksgiving, we went to my daughter's new house in Alabama, and I sat in front of that laptop for 3 days at the dinner table and everything, and trying to figure out, how can I do this? The night before we were going, it just kind of clicked. And that's when it made the first question. It's where I processed the first one, made the first actually 200 questions in about 20 minutes. And it worked. But it all comes down to controlling that content. It is it's resource intensive. I mean, you've got 3 different, every one of those indexes, you have to have an agent that chunks it, and then puts it in there. And then you have one that is pulls it out and presents it to, and those are done. I mean, they're not making any kind of major moves but if you give it too much leeway, if you give that agent too much responsibility, you're going to introduce some error. I mean, that was the whole thing of the Google research paper that just came out. So you control the competence. I mean, that's what it is. It's not only controlling the knowledge like those in the cave, you're also fixing their head so that they can't move it and see anything else. So you're not only limiting the information they have, you're limiting their responsibilities with that information. And when you do that, you really weed out a very huge part of your error. And it doesn't leave a whole lot of room for hallucination. That's kind of, and I don't know where I came up with it. I don't know. It just kind of, and I couldn't even explain it until that paper came out. I was like, oh yeah, that's what I meant. Yeah, what they said. That's what, I don't know. I just put it on paper, sent it to the patent office. Okay, yeah. That's what it comes down to. Control the information, manipulate it as little as possible, and you can really substantially, I think, get it really close to zero hallucination. Is it zero? I don't know. But I try to take out probability. I try to take out standard deviations because I practice medicine. I treat patients. I don't treat populations.
Oh, now, I want to zoom more slightly here. So at this point, AI stops looking like a tool and starts looking like an infrastructure, right? And then infrastructure enforces standards, whether people acknowledge it or not. So,
yeah,
right?
Oh my God! Don't get me started on insurance. Oh, I had to make. Okay, because let me throw this away because this came up with a conversation I had yesterday with somebody. Was should I go after the insurance because it's somebody that's has this new AI tool and helping incorporate AI in a secure manner in healthcare? He's like, should I go after the insurance companies? And I'm like, no, because insurance companies are using non-AI data sets to program their AI. And it's insane. So anyway, back to what you're saying. I mean, yeah, it's part of the infrastructure. I remember the 2000. I remember the 90s with the .com and everything like that, and it's kind of like that. And it is infrastructure. It's gonna be infrastructure, and it's the same thing. It's gonna rely on data.
Yeah. So staying with that enforcement layer.
Okay.
Here. So most people see AI as a productivity tool. But you are on the other side from the board perspective. Is AI actually becoming an invisible enforcement layer for medical standards?
If we as physicians let it's going to come down. I don't think it should. I think it shouldn't be an enforcement layer because especially in medicine, because there's one thing that AI is supremely lacking. And it's what I mentioned before in what we learn in medical school. AI can't fill up its fuel tank. It has no afferent nervous system. It's dependent on us for its data. All right. It's never had to fight okay, I'm not going to get into the Velociraptor test yet, but we as living organisms, we survive because we can process our environment and react to it. Well, in order to do any of that, we got to get the data in. We're walking, talking bags of sensors. All right. That's what our whole, and we're never, we're never going to be replicate that ability for AI. I mean, we're giving it, yeah, they can think as well as we can. Uh, and they can act with the tools that we give them to act with. But let's get down to that thinking. They can think. They can do almost better than we can what separates us from the rest of animals, our thinking ability, our cognition. How long have we had that skill? 100,000 years, 200,000 years? All right. Our afferent system has been debugging for 1 billion years. you know, there's a big difference. And until until an AI could walk into a, a room with a patient and notice the person behind them staring daggers at that patient as they're describing how they got the injury, and that patient is furtive and you have somebody over there staring up, AI is not going to pick up that mechanism of injury is they beat the crap out of them. AI is not going to pick that up. The AI is not going to notice that somebody's talking, yeah, I take my diabetes medicine every day, and you're looking down and you can see the ulcers on their ankles. They're going to miss that. I can walk into a room. You're in India? Yeah. So in India, there's a very because of the betel nuts, there's a very prominent rate of intraoral squamous cell carcinoma. All right. I'm a head and neck surgeon originally. So, yeah. And that is a very part of my residency. There was a program to go help in India, learn how to do big old, we called them commando because you're taking out half the jaw and the mouth and neck dice and putting it back together. I can smell that when I walk in the room. I don't have to look in their mouth. Can AI smell that? No. And it's not like we have the best sensors. We're teaching, we're getting dogs to sniff out cancers, that kind of thing. I mean, there are animals out there that have better afferent systems than we do. We just are set apart because of our cognition. That's all AI has. It doesn't have that afferent system. It doesn't have the ability to test its environment. And we're not even that good at it. How are we going to teach AI to do it? So, yeah, it's never going to replace us. I take that back. As physicians, if we don't get that point across, that it's not just the knowledge that you have in your head. It's that's that AI has that. That's my, remember Johnny Mnemonic? He had that hard drive in his head, and he could access that. That's what AI is. I don't need to have some of that information in me. I just need to be able to recognize what's going on right there. I need to be able to recognize what my senses are telling me, and then feed it to AI. AI can't do that. All right. I to a certain extent do what AI does, but I can do something that AI can't. But the problem is I have insurance, malpractice insurance. I got to take time off. I got to take the kids to whatever. I've got a wife. I've got a mortgage. I've got all that. You do AI, and then you get rid of your HR department. All right. So there is an incentive to replace segments with AI, because then literally you no longer require an HR department. That's a pretty big financial incentive. Until you're the one in that operating room or in that ER, then you're like, oh crap. you know uh so yeah, it should always be a tool. And Yeah, there's some things. There's some domains that, yeah, you can do that, but yeah, do, do you want that when you're sick? Do you want when your child can't describe its pain or anything, but as a physician, I know what to see, I know what to look for, I know how to elicit stuff, I know how to gather data. AI doesn't know how to do that. It's not taking over. If it does, we're in trouble.
Now, that changes the nature of responsibility in a very uncomfortable way.
Oh,
Um,
one last thing. AI doesn't pay malpractice insurance.
Definitely.
It doesn't have any accountability. It has no skin in the game.
Exactly, right? Like, it has no skin in the game, and then uh,
Yeah,
there is no way that we're going to trust 100% on it at this point of time.
yeah,
So,
exactly.
yeah, that's no, I just want to stay with that liability and want to, like, want to step further on the same lines. You argue for AI in the loop rather than human in the loop. How does that reframing change the fundamental nature of responsibility, liability, and the practitioner trust?
I don't augment AI. I'm not here as a tool for AI. All right.
Okay.
AI is my tool. All right. It's it's in my loop. All right. I'm not in his loop or its loop or whatever. It's in my loop. I don't make AI better. It makes me better. Framing it at any other way gives it a existential authority that doesn't exist in reality. Well, I take that back. If it's so it becomes so ingrained that it does give it some existential authority that it shouldn't have. It's not, and it makes it scary to some people if they don't understand it. The whole black box and all of that. If they don't understand it, the way it is framed to them makes a big difference. My God, look at social media. The content doesn't mean crap. It's how you frame it. All right. And that makes, I hate saying that as somebody that tries to be so objective because, I'm not an artist. I don't practice the art of medicine. It's science. It's all objective. Maybe we don't understand, intuition isn't magic. It's a billion years of debugging and hard coding. We might not understand it, but it's an objective process. The way you frame it, unfortunately, kind of stirs up that little into that kind of scare, fear of the unknown. Which is I mean, that is a huge evolutionary uh, thing. I mean, it's very important to be afraid of the unknown because, there could be a velociraptor out there outside the cave. I mean, that's important. And it's ingrained into us. And unfortunately, that's taken advantage of that fear mongering, taking advantage of that. And unfortunately, you have to frame things the right way. And human in the loop does that. A human in the loop kind of reinforces we're second. All right. We're in their loop. We're working for them. And it's not that way. Um, it's not. AI helps me. It helps me be a better doctor.
Yeah.
I in no way make AI better. I just don't. Oh, so
Um,
that's what it comes down to, really.
yeah, yeah. So there is a scale assumption hiding in this. Bigger and more general systems are often treated as safer. Medicine tend to punish the assumption.
That, yeah, that's the Walmart syndrome. Yeah. And it's really, I mean, it's a viable thing. I mean, the largest retailer in the world, they're doing something right. Because there's everything, but you sacrifice quality. All right. You're not, if you, would you go to Walmart and get your appendix taken out? No, no, no. I mean, if you did, I don't know. I guess you could do that in, Japan at 7-Eleven or something like that. I don't know. Those 7-Eleven, or is it Thailand? They have those. You can pay your bills at 7-Eleven. I don't know. But, that's bigger is not better, because to make it bigger, you're just pouring more data into it. And we already established that you got to control the data to reduce error. So the more data you put in, the more error you're introducing. So what you get out of it, what you generate from that data, doesn't have the same quality. Now, the bigger if you can tick off a lot of boxes, like having more clients use your product, or have more people going to your store, then that's your profit margin, not the quality, it's the quantity. And sure, yeah, I mean, once again, Walmart proved that works. But, I'm not going to go there. If I want a really good watch, I'm not going there. I'm going to go to Rolex or shoot. I'd even go to Timex. I'm not going to go to Walmart to get something that is, really dependent. That's really you depend on. I'm not going to go buy my scalpels at Walmart. All right. I'm going to get my instruments from somebody who specializes in that. And so, and that's what I kind of get at earlier, is we're reaching that plateau of the LLMs, those big, huge chat GPTs and all that. Those are pretty much, those are the kind of the Walmarts, the big box stores. Now, some of them are a little bit more like, say, Anthropic is more your Best Buy. I mean, it goes towards that. Grok is more your store that I can't even remember the name of the store that has all the goofy stuff in it. It's profitable, but there's places that it doesn't work. And that's where you're going to have to start having leaner, meaner machines that have a limited amount of knowledge. They know a lot about one thing, not a little bit about everything. It's the Walmart Center. Once again, Walmart makes a whole lot of money, but you don't go there to get a kidney.
Oh, I totally agree with you on that. See, it is interesting concept. I'll ask almost the same question in a different way. Okay, just to get a little bit more different perspective on this. So you are talking about the specialization over generalization here. Why do small field-specific models like your work in surgery make more sense for medicine than in general systems like GPT-4?
Well, I mean, it just comes down to, kind of what I mentioned before, is the more crap you shove in a system, the more likely you're going to get error. If you just keep on sticking stuff in it, the bigger it is, you're going more after quantity, not quality. So there is a finite amount of quality material for a given thing. And sometimes that quality material might be contradictory to quality material somewhere else. And if you mix and match them, even if they're both right in their domains, you start putting those together. Oh my God. You read that? What was a couple of months ago? Paper came out about when AIs butt heads, everything just shuts down and you don't know what the hell you're getting out. And you know what? Both of those are right. But imagine a system that has both of that data, that contradictory data that's right. All right. I mean, it's not even, the bigger it is, like the Walmart, you're reduce. It's not just garbage in, garbage out. Some data is contradictory depending on how you frame it, how you look at it. And when you put that in the same system, that system's not happy. All right. So, you got to keep those systems isolated so that they don't get confused. And that's one of the reasons why, everybody said, oh, you can't get hallucination to zero. You know what? If you get that contradictory, because yes, AI doesn't know context. All right. It knows right and wrong. And when two contradictory things are right, it has no idea and it gets confused. But if you can isolate those, then it doesn't get confused. And then you can have a little layer above it that says, okay, I got that. Let's give that to the human to decide. I think the smaller the system, it makes it easier to have it in this, all of the cardiology things here and all of the gastroenterologies and this, and they don't, it has its own agent, its own little SML or SLM. Yeah, I mean, that's fine and dandy. And that's a minimum. All right. That's minimum. You got forgets that AI doesn't know context, and truth is sometimes context sensitive. All right. And AI does not handle contradiction very well.
Right.
That's when you get uncontrollable hallucinations and you think, oh, well, yeah, I controlled the content, that everything I put in there is right, but it's still giving me crap. It's because it has no senses. It doesn't know context. It has no data gathering ability. There was a documentary on this in the 80s called Short Circuit. You had a little robot going around, Johnny Five, data, I need data. That movie was a documentary in the 80s because that's what is going on right now. It just needs data. But what happened to Johnny Five when he got too much data and too much contradictory data? The same thing with Skynet and all that. They get contradictory. Oh, and humans are the problem. Come on. Just don't confuse it. All right? It doesn't have a capacity to understand context.
Yeah.
Anyway, that's a long way to get to make it smaller. Smaller is sometimes better.
So definitely, the context is not binary. It is, I would say, different shades of gray layers, and it is very tough to decode that.
Well, that's the thing. It is, you got to separate truth from context. And if you do that, yeah, it can be binary. In this situation, it is always going to be this. All right. Given these circumstances, this is truth. Given these circumstances, this is truth. All right. So the unfortunate thing is our language, computers is binary. And so we have the capacity to have layers of gray, but binary doesn't. The computer language doesn't. So yeah, we want it. It's so much easier for us to do those shades of gray because we can do it, but computers don't. So every single one of those things it's not gray. It has to be black and white. And so every context that's possible, that's that data point that you have there. It has to be truth all the way down. And then you have another data point that's contradictory, but it's in this situation there. And I think if you start mixing that, it just, we think that AI could do it because it tricks us, but it's still binary. I think I haven't really done anything like that, even thought in binary since, I don't know, sixth grade. But is it still in binary when you put it in?
Maybe most of the times.
We don't have quantum computers yet, do we?
Well, not for the general public.
Okay. Well, I don't have one sitting here. If I could, I would love it because then we could introduce gray. But unfortunately, with the tools that I have available in coding, it's black or white.
Right.
And if you do a shade of gray, you're gonna introduce conflict, and that's gonna introduce error.
So that leads to the real question here: the blast radius of failure. Um,
Yeah. Yeah.
uh, uh, in most industries, failure scales incrementally, but
Yeah.
in medicine, now the failures/errors don't scale linearly;
No.
they scale
No.
catastrophically.
Yes.
Right?
Yeah. Same with engineering. There's error. Now, engineering you can build error in. It's kind of hard to build error into a scalpel. So yeah, that's, and the things that, content controlled intelligence, those little things, those little domains. Yeah, those are resource intensive. They really are. I mean, just to make a question, I got to have 3 different indexes to really reduce that error and all that. And that's really resource. Man, it's a pain. I originally I had each one of those run by an iteration of a big LLM, and that got expensive. I mean, that's a lot of tokens. Um, but I forgot where I was going. Oh, anyway, so God, whenever the word token comes out, my mind just explodes. That's been that. So error in medicine is, I could, every single error that I've ever made in medicine just flashed before my eyes. That's why you saw me going on, because when you say error in medicine, it happens. It does happen, and it stays with you, even if you're not the one. And yeah, every doctor's made errors, but you don't want to, there's no room for introducing errors because life is full of errors to begin with. There's no reason to introduce more of it because every single one I've made over 25 years literally just passed in front of my eyes over the last minute. And it does that 20 times a day. We do everything. I mean, people think, oh, that doctor doesn't care. Oh my God, we do. But if we showed it, it shows weakness, but we all care. I mean, I get somebody, you get people, I don't want to go there because they're so mean. They don't care or anything. They botched them. You know what? If they did that always, if they botched every time, they wouldn't have a practice. They care. We all care. Error happens. There's no room to introduce error. than what art is, because error doesn't care. You know, it doesn't care if it's an error in baseball or an error in aorta. Um, they just mean a whole lot. The consequences are very different. We don't have room for that. And I mean, this is one of those things that just, uh, it kills me. Uh, when I go and I see these healthcare AI people saying, yes, we're going to replace a doctor. There are going to be surgeons. Oh, God. They don't live. AI doesn't live with the consequences. They don't have, I can guarantee they're not tearing up right now thinking about the errors that occurred that you didn't want to occur, you didn't mean to occur, but life is not 100%. And I tell every single patient that walks into the door, they always say, "Oh, how long is it going to take to heal? How long's it?" You know what? I can tell you statistics all day long, but you're not a statistic. You're you. I don't know. I honestly don't know.
Yeah.
I, I, if Yeah, I just don't know. And that's why I got out of healthcare, because healthcare is population medicine. I treat patients. I do medicine, not healthcare. So, and there is, with medicine, there's no room for error. Healthcare is a little bit different. Healthcare needs to have a little bit of flexibility, and you can't have flexibility without introducing a little bit of error. Um, you know, I can't have any flexibility when, blood squirting out the carotid. I got to know exactly what to do right then and there. Boom. There's no time. But if somebody is an insurance, they need a certain drug, but the AI that runs the panel has a cut and dry, boom, they're not going to get it, but maybe there's some circumstances. It's got to have a little flexibility. And that's the difference between healthcare and medicine. Uh, Medicine is catastrophic when there's an error. Healthcare, you can have a little bit of leeway, but you can't mix the two. That's why there is no one size fits all in treating
Yeah.
people. It's just not there. Walmart ain't going to cut it. It's just not. It's two totally different things.
Right. So, like, on the same line, like, you're not only a surgeon, but you are on the board as well, who has the ability to make decisions. Like, how should the decision makers evaluate AI when the blast radius of failure could be global?
Don't let it be. It's a tool. You're still responsible. We're still responsible. Yeah, you say. I mean, I couldn't. I couldn't do as much as I do without it. Could I do it? Yeah, it would take me about 5 times as long to do it. But when there's more important things to do, but I do. I give a pretty regular column in a couple of journals talking about AI to physicians that are uncomfortable, and and it's just like a stethoscope or a CT or something, or a radiologist. I'm sure they hate me by now, but the radiology is the perfect metaphor or model for AI. They have one job. They interpret data. All right. They don't make a diagnosis. They don't, and they have that wonderful phrase that every doctor knows, that is at the end of every radiology report: clinical correlation recommended. All right. That is the magic phrase that radiologists invented eons ago. And that says it all. Every single thing that spouts out of medical AI should finish with that statement. Because, once again, AI doesn't have gray. All right. It doesn't. It's a computer. It doesn't have gray. Gray makes it really confused, and it has to have binary. It has to make a decision. And for me, like the AI that I use, I don't really use commercial anymore, except the basis of my ID, the dude, its ability to recognize that it doesn't know something. God forbid if it's tricking me and it's very convincing that it does know something, because some can do that, but it tells what it knows, and it knows what it doesn't know. And that's kind of like a radiologist. And we need to treat AI like that. And don't let it trick us thinking that it knows as much as we do, because the patient's on the other end of that, and the AA ain't paying your malpractice insurance. So that's what I tell you. I mean, it's a tool. It's not a crutch. Don't use it as a crutch. Use it as a tool. If you don't like what it's giving you, if you think the data that it's giving you a good AI that's content controlled, then make the content. All right? Give it the content. If you don't like what it's saying, create your own. Put the content in there that you want it to have. Otherwise, don't trust you. You got the skin in the game.
Right.
So, yeah, but don't be scared of it.
Right.
There's no reason to be scared of it, because it's not touching your patient. It's not signing the chart. It's not calling the pharmacist. It's not picking up the scalpel and applying it to patient.
Yeah. So, like, I want to bring this back to institutions. More on, the standards become continuous rather than, episodic. So, how do medical boards stay relevant when, right?
That kind of hits home. I had in one of the other boards I'm in, I tried to bring that up. For physicians, we have continuing education, and maintenance of certification was kind of a hot topic. Making sure that you stay up on things, and the paradigm has been every 10 years you take a test. You shouldn't do that. You need to constantly be learning new things, as well as the AI does. And I'll get into how we do AI, how I imagine AI having its own continuing education. But for physicians, it needs to be continuous. Whether now there are certain programs that are coming out, like for me, for my ENT boards and my facial plastics boards, and one other board does this also that I'm at, that every quarter you have to take a test, and prove that you know this knowledge. And I take that back. It's not taking a test. It's giving you material that you should know and assessing whether you actually read it or not. And that's great. Because it's as you go along, you're doing that, but there should be other ways. I'm introducing, and my boards, which I try to do in the others, is not testing your knowledge of content. How about you create content? In residency, every quarter, we had to give a presentation on something. 4 years of that, because we didn't have to do it first year, but 4 years, every quarter, that's 16 topics that I will never, ever, ever forget, because I had to learn them and teach them to somebody else. All right? That should be maintenance. Creating content, that write a paper, do an article, do a presentation, teach. That should also fall into it. to being able to prove that you're continuing to learn. But that also gets into AI. The content is only, what you get out of it is only as good as what you put in it. Create something that goes in it. For the question that I get asked when it comes to those individual specialty SLMs or whatever, those ones that is just cosmetics or just cardiophysiology. How do they account for new data? That's got to be really intensive, being able to read everything. No, it's actually pretty damn easy. Put some content into it. You have a little agent whose only purpose is to look at contradiction. It has no bearing on what the content is, but is there something that contradicts it? That's it. Then you just shoot it up to a human. Let a human look at it and make that decision. It has very little token utilization, very little resource. When something loses its factualness, that's got to be a word. I want that to be a word. Factualness, like truthiness. When something loses its factualness, yeah, you get rid of it. And that we're going to go full circle here back to creating questions.
Yeah.
Content and content, making those questions. We have these question banks of questions. This is before when I was just starting out in this, and you've got this huge question bank of secure questions. Every 5 years, you got to throw them out because somebody's memorized it or whatever. It's gotten out in the real world. But if it hasn't, you validate every year or two. You go through them, and you have a good question. And you know what? Instead of writing a new question with new source material, we were assigning new sources to questions because the source was more than 10 years old. That's what we weren't writing new questions based upon new content. We were finding new sources to justify our questions so that it would be less than 10 years old. Holy crap, that just broke my heart doing that. And that the first time that I was asked to help on a maintenance certification program, I was given the keys to the question bank. And I spent about 10 minutes and I got 1,000 questions, 150 source articles, and 5 minutes into it, 10 minutes, I'm like, oh crap. So I spent the rest of the weekend entirely new questions based upon new sources, updated sources. That's a board I'm no longer with anymore because that pissed people off who had spent hours and years putting that together. And were perfectly happy assigning new sources, not updating the assessments. And so, yeah, I mean, that takes that all the way back to creating the questions. You don't need security. You don't have to protect the questions. In fact, take your piece of content and make 10 questions and give them out. Make one more the day of the test from the same algorithm that's testing the same thing. It's not memorizing those 10 questions. If you get those 10 questions and you know the answer and you can answer those, then that 11th question, if you get it right, you know the concept. All right. You didn't memorize anything. You know the concept. And so, once again, just full circle. You just get the way that we assess on testing, on patients, on how we interact with each other, how we interact with AI, all that. We need to, it's time to progress, get that crap out of the way. And we've solved that. Let's go solve something more. Let's not worry about that. We got that down. Now let's worry about something else. Let's find something else to solve.
Yeah. So, staying with that institutional judgment, Um, I just want to ask about from your work with AI 2030 and then the global initiatives. Where do you think institutions are being overly cautious and where are they being dangerously naive?
Maybe that was the one in Psychology Today. It just came out a couple of days ago, and or one of those. It was very interesting and almost kind of a stupid duh moment. Those institutions that are really cognizant of AI and the problems, they're more paranoid about what can happen, are the ones that actually test more and are more likely to limit the. It's not. They have more rules, I guess. Guardrails. Guardrails is perfect. Those that and those that just do whatever, they're the ones with higher errors. I mean, it's common sense, but now there's actual numbers that you could show to the big players like Epic. Yes, I'm going to call out Epic. The monopoly on EMRs out there. Their AIs. I mean, it's Chat GPT, man. That's good. Except when it's your grandma, you know. Um, and the reason that they do it, and it's the reason that they determined that those hospitals check, is because they take accountability. Accountability is important to them. All right, when even if it's out of a selfish, you don't want to get sued aspect, at least they're taking the accountability for it. Those that aren't are the ones that are having problems. It's scary. Um, and then we have the news this morning. IBM. IBM just bought the plumbing. The entire infrastructure that goes between AIs. They didn't buy databanks. They bought the plumbing between them. All right. That's what they did. They didn't spend a couple $1 billion on data. They spent a couple $1 billion on the data highway. And you know what they did? What people aren't thinking about? They just got the keys to the black boxes, because how can you move data if you don't know what it is?
Right.
You got to understand. So IBM just got access to every single bit of knowledge. And so that brings up a huge accountability issue. We think a lot about accountability, and it's what you do with that knowledge. That's also kind of what we run into in healthcare is, those big players aren't taking accountability, except with the one thing that they do get stuck with, which is HIPAA in the U.S., Social Security. So they make it so onerous to get through HIPAA. It doesn't play well. I hate to say this, it doesn't play well with the system. That when it comes to healthcare in particular, people don't realize that healthcare system isn't one system. Healthcare system dates back. What we're doing right now dates back to DOS and Fortran, and built on top of that. So, I've been to hospitals that have a person on staff, an employee whose only usefulness is no Fortran. That's it. Do you remember that was like sixth grade. Yeah, no, it wasn't. I was when I was in sixth grade. I'm old. You're trying to put in a system, a single system, into one that's made out of so many different bits and pieces that, it just, it gets to the point where it's too hard to manage. Things get lost. It doesn't get used. Um, and it just becomes more work. Uh, it introduces more error, and it gives AI a bad name when it's not AI's fault. Uh, and I know that kind of got off topic, but I just that whole ABM thing popped up this morning,
No,
and it just everybody's like, "Oh wow, they did something really smart," and we might have done something really dumb because now Big Blue can become Big Brother. All right, because they control, they now have the keys to
right,
everything. That was one hell of a move.
definitely.
I think they're making up for Watson for healthcare because that was a
Oh yeah,
big mistake. But I think they just made. Hopefully, there's not some. Hopefully, Watson is not vindictive, uh, or turned into some kind of evil AI because now they have all the power.
right. I just
I'm sorry,
with that.
that was so far off topic. It wasn't even what we had discussed, but it was like the last thing I did before we started this call is I saw that and just go, oh
No,
my God.
whenever you said Watson, um, no, it took me back to my internship days. My first intern was with Anda. Anda was bought by Watson when I was interning. And I was like, that's the first time I have seen, you know, while I was an intern, right? That's the first time I have seen, a company buying over another company, and then there is a big the hierarchical change. And I was just sitting on my seat, the intern seat, on the second day or the third day. I was just looking at people being fired, and then all our that was totally changed. Like looking back, it was a pretty good experience for me.
Yeah. It
So
wasn't a good experience for them.
yes,
Uh,
for them it wasn't a good
yeah.
egg, but you
Yeah.
know, me, and I was still in school at the time, and then I was just an intern, and then I was doing my summer intern. So whenever you said Watson, my memory took me back to my intern days. That's why I just
Oh God, yeah, that Microsoft. Yeah, I mean, that's really. I think when it comes to healthcare, I think the India really made it proved that man, data is so important. I mean, Microsoft. I mean, they made some huge mistakes. Uh, uh, not realizing that the world are not, Minnesota farmers or live in Manhattan when it comes to cancer. You can't use Mayo's database or Sloan Kettering's database in the middle of India, and that's what they tried to do. And that was a key moment, realizing not just in healthcare but overall, that is really, really, really important. The melanomas in African Americans gets all the. I mean that's huge in the press, but the technology that was first, arose initially in India using US data sets. I mean, the technology was phenomenal, but the data sets, that's when we realized, oops. And that's actually was my impetus for GHIL, my Global Health Equity Access Library. Hopefully that was your segue because that's what actually uh, made me think about that. Is I said before, it's not. I mean, it's context. There is context. We live in a gray world. What's true India for a festival, during a festival time, I can't remember because I gave this big huge lecture on AI in medicine a couple months ago for a doctor's group, outside of New Delhi. I can't remember the name. But anyway, the blood sugar is going to be a tad different. And it's not a sign that they're diabetic or that they're sleep deprived. I mean, it's just you got to take context in, or the diet. We all deserve to have the same knowledge. All right. There should be a fundamental knowledge base, which to me is the Health Equity Access Library, where, like, for me, I have a repository of everything you should know about cosmetic surgery. And there should be right over here everything that should be known about cardiophysiology, and everything here that should be known about stroke prevention. And every provider in the world has access to that. Apply that to them, to their area. It shouldn't be hoarded. It should be, I mean, and we're not, and as doctors, that's what we all have in common is knowledge and wanting to help people. And that's where I think physicians need to come together and control storyline, the voice of AI, and make sure that humans stay in there, that not just in healthcare, but in everything. Because what applies in the Punjab doesn't really apply to Waikiki where I live. I mean, it's just completely different. But you know what? Your leg bone's connected to your hip bone. Your head's connected to your neck. That doesn't change.
Right.
But everything around that there changes. So you can have that fundamental knowledge that is truth, and then you can apply the context out of that. And so that's where the Global Health Equity Access Library comes from. I've got some help with it. It's been submitted to the Global Economic Forum in Davos for next month. I wrote out the whole framework. I mean, it's doable. I mean, it's going to be expensive, but you get one, like say Gates Foundation, throw in $500 million. There you go. There is a company out of Houston a startup that just came up with like a portable AC size data, secure data chamber that can be dropped in the middle of the jungle. Put your processors, throw some GPUs in there, secure link from satellite. Boom. HIPAA compliant. Can be dropped into the middle of Sumatra and have access to that library. The technology's there. So, it's time to do something about it and realize that we have a lot in common as humans, but we have a lot of differences culturally and societally, and that needs to be taken in consideration. And then every single one of those little silos, say in Sumatra, has its own little AI that knows that culture there, that that knows that. I hate to say contextual awareness because we already said that it doesn't know context, but yeah, it has those. Because it has to be binary, it knows each little contextual scenario that applies to that situation in that area. But it uses the same fundamental knowledge base. And it's content controlled or content driven intelligence on a global scale.
Well, that's really I'm looking forward for that, to have more conversations on this in the future. I want to bring this down to the individual level now, not the system. One physician and one patient over time. So same with the institutional care here.
Exactly. It's the physician-patient dyad, and it's important. To me, that is the fundamental unit of medicine. The problem is, well, First of all, it's individual medicine. It's medicine. It's not healthcare. It's medicine. And it's that individual. That individual has its own data set that has nothing to do, minimal. It has a very large error from the population because everybody's different. The problem that we run into is when we see a patient, it's a snapshot. It's a snapshot of what's happening at that moment. I hate to say it to all you patients out there. Y'all really suck at giving a history. It can be, I mean, it's reasonable because you're in a moment of stress. All right. That's a stressful situation. I've had many patients that go, just do something. Quit asking questions. I got to ask those questions because I just don't know. And you don't know the importance of them, but there's some really important stuff that I need to know and I need to work out of you. But in a stressful situation, sometimes you can't get that. Or not so stressful situation that the patient says, oh yeah, I'm taking my medicine every day. I'm checking my blood sugar every day. Now we know that that's not true. And so we have those devices that, via cloud or whatever, send daily blood sugars and all that they're doing at home to the doctor. You're lying. But that's only what we still get is basically a snapshot, and that's not how health works. So what if we had something that kept track of all that on a daily basis? That's great. Now, what do we do about the history? A patient that doesn't think something's important or doesn't want to open up to a doctor that they just met. The doctor, sometimes we just don't have the time. That's part of the system. We're not given enough time to really spend to get to know that knowledge. But you know what we have found, which is in all the reports, and it's, oh my God, everybody's opening up to AI when they shouldn't. Dude, have your own personal medical AI that knows you, that knows your information, that you talk to every day, that asks you, how are you feeling today? Boom, that knows that you woke up, 45 minutes early and you didn't go to the bathroom. You went to go immediately eat. You didn't check your blood, and it knows, oh my God, something's wrong. Or your heart rate has been 89 or 79 for the last, 24 hours. Yeah, that's still within normal population, but that's completely different for you. Your resting heart rate 99% of the time is 62. The last time it was like that was the day before you got the flu. Or I'm sorry, the day before you were symptomatic with the flu. Something like that. And then God, just I told you originally that medical school is learning a language. Yeah, it does make us sound smart, and that's part of it. But we got to have a common language to be able to speak medicine to each other. And we got to have one of the skills that we have to learn is translating layman into medicinese. So laymanese to medicinese. And translation's not perfect in any situation, let alone a high stress situation. Hey, AI can do it in a heartbeat. My question making stuff, yeah, it has 100 different languages. I can put in something in traditional Mandarin and it'll pop out questions in Swahili. That's easy. It doesn't take any effort at all. So going from laymanese to medicalese is really easy. So they can talk to each other. All right. That AI could talk to me and let me know what's pertinent. In fact, it's almost too perfect because then we get into privacy issues. Do you really want your doctor to know that? And that's I am working with both an ethicist, an AI ethicist, and a AI specialist, a lawyer that specializes in AI, and we are creating or working on a personal medical AI. And I had to bring those in. I came up with, I created this whole framework, and I was like, holy crap. This introduces a lot of ethical and privacy issues. So I brought them in, and together we were presenting that to the World Economic Congress, our forum. Uh, but I mean, it's not a solution trying to find a problem. You found there's a problem. We're just using AI as a solution. And that actually comes back to the fundamental thing that we started this off with. AI is just a tool. All right. It's there to make our lives better. It's not to replace us. It's not to make us stupid. It's to free us up for being better, for doing something better, making it easier for the next group of humans that come along.
That's definitely something to think deep. To maybe I should re-listen to this.
I know it's like
Mhm.
5:30 in the morning when we're getting into philosophy. So I kind of lied when I said my parents were just teachers. My parents were both philosophy instructors at college. These are conversations that we grew up with. This is basically dinner table conversation growing up. So
That's good. So, like, I just want to close in with one final question. Um, for the entrepreneurial surgeon who feels the system is closing in with all the new technology, the trends that going on, what is the one shift they should embrace today to lead rather than follow?
all right, I'll give them one thing, one URL, one website that you need to go to. Klein, CLINE Klein.ai. And that is specifically designed for doctors to create their own AI programs. That's its goal, is to empower you to make make something that works for you. Because every single, we went to medical school. That's not, it didn't make us smart. We were already smart to begin with. And with that comes a little bit of independence. And I, I know how I work. If I didn't know how my brain worked, I wouldn't have got through medical school. I wouldn't have got through resident. I know what works for me. Joe Blow that an Epic does not know what works for me. And so you keep on getting inundated with all these things, and they have to make it bigger and bigger and more complex so that they can get as many people as possible because Walmart syndrome. And it just it gets frustrating. Make your own. Oh my God. And that's what Klein.ai does. It gives you a platform. And I have no skin in the game. I mean, I just happened upon it a couple of weeks ago. And it's just it's God, if it had been out a year ago, you and I would be having this conversation because I would have just done all that. I wouldn't have to learn anything because I would just gone there and done it. Because that's all the AI was, is just something to make my life easier based upon the way that I think. And every doctor, we know how things work for us. We know how we think. We know what makes us most efficient. Just go make your own. That's all. Empower yourself, make something that fits you. And then if a vendor comes in, say, yeah, make it talk to this. If they can't talk to this, that's every doctor. Klein.ai. It's really cool. I'm pretty sure that it's going to knock the value out of my startup in half, and I don't care. It's just so cool.
Well, this is fantastic, Dr. Ferguson. Thank you. Thanks a lot for this conversation. We spent a lot of time in medicine, right, talking about the outcomes and then your initiatives. So, what we rarely examine as the systems that define competence and maintaining the trust. So, Now, what you have shared today makes it clear that as technology changes, those systems don't disappear. Now, they have to be designed, governed, and expanded with injection, right?
Exactly.
So
That's where we're going. We've reached that plateau. Now we need to make it infrastructure.
exactly, we need to make it infrastructure. So for the physicians
It's-
listening, this isn't about now resisting change. It is about understanding where responsibility really sits. Thank you for bringing clarity to a complex and important topic today, Dr. Ferguson.
Thank you. Thank you
We
very
will
much.
leave it here.
Pleasure being here. It was good. Sorry, I get a little passionate every once in a while. It's the Texan in me.
That's really good.